Hello everyone, my name is Elnaz Hamedi and I am currently pursuing my doctorate in executive leadership in mental health and human services. Today I will be presenting on an important and timely topic which is called mental health disparities among minority populations. Houston is one of the most diverse metropolitan areas in the United States, yet mental health outcomes are far from equitable. Minority populations, including African American, Hispanic Latino, Asian American, and immigrant populations, continue to face systematic barriers such as lack of insurance, cultural stigma, provider bias, transportation gaps, and socioeconomic instability. These factors cause preventable delays in treatment, underutilization of mental health services, higher prevalence of untreated mental health conditions, and poorer long-term outcomes. The purpose of this program is to provide a culturally grounded, accessible, community-centered response. This presentation will cover the rationale for the program, its structure, its measurable goals, and its evaluation processes with the goal of demonstrating a program that is both evidence-based and realistic for implementation. It will present how this program can serve as a model for reducing disparities and empowering minority communities in Houston, Texas through education, advocacy, resource coordination, and collaborative partnerships. Mental health disparities among minority populations in Houston, Texas stem from a complex interplay of social, structural, and cultural factors. Minority groups disproportionately face elevated stressors such as poverty, exposure to trauma, discrimination, lack of stable housing, and workforce inequalities, all of which negatively affect mental health. Despite experiencing equivalent or higher rates of mental health challenges compared with white populations, minority communities remain significantly less likely to receive high quality, timely mental health treatment. One major contributing factor is limited access to affordable care. A large percentage of minority residents in Houston, Texas either lack health insurance entirely or are underinsured. Without coverage, individuals delay or avoid treatment, resulting in worsening symptoms. Furthermore, the number of culturally competent mental health providers who understand the lived experiences, languages, and cultural norms of minority groups remains limited. This mismatch leads to distrust, miscommunication, and reduced treatment adherence. Another issue is stigma, particularly in African American, Hispanic Latino, and Asian American communities, where mental illness is often viewed as a sign of weakness, a family burden, or a moral failing. Stigma suppresses help seeking, minimizes symptoms, and contributes to higher levels of internalized shame. Additionally, structural racism within healthcare systems results in misdiagnosis, implicit bias, and unequal treatment outcomes. Urban factors in Houston, including transportation barriers, long clinic wait lists, limited availability of bilingual professionals, and economic inequities further widen the gap. Ultimately, untreated mental health conditions contribute to rising rates of homelessness, substance abuse, educational challenges, unemployment, and chronic illness. This problem requires a coordinated response that addresses both service gaps and systematic inequities. Understanding the nature and scope of mental health disparities is essential for designing an evidence-based program capable of meeting community needs and achieving equitable outcomes. The target population for the program, Mental Health Equality Advocacy, is minority adults ages 18 to 16 residing in Houston, Texas, with a particular focus on communities that consistently experience the highest mental health disparities. This includes African American, Hispanic Latino, Asian American, Middle Eastern, and immigrant groups living in low income, underserved neighborhoods. These populations often face overlapping risk factors such as limited insurance coverage, language barriers, generational trauma, and reduced access to culturally competent care. Within these communities, the program prioritizes adults who are at heightened vulnerability for untreated mental health conditions, including depression, anxiety disorders, trauma related disorders, and chronic stress. This population was selected due to data indicating higher unmet mental health needs in adults, greater exposure to socioeconomic stressors, and longer delays in treatment initiation compared to other demographic groups. Additionally, many minority adults in Houston, Texas work in industries with high job insecurity, limited mental health benefits, and inconsistent access to transportation, making traditional clinic models making traditional clinic models inaccessible. The program will particularly focus on individuals who lack insurance or rely on Medicaid, prefer treatment in their native language, face immigration-related stressors, have experienced discrimination or bias in prior healthcare interactions, are reluctant to seek help due to cultural stigma. By engaging community centers, faith-based organizations, local nonprofits, and neighborhood clinics, the program will reach individuals who often fall outside traditional healthcare pipelines. Outreach strategies include bilingual workshops, community ambassadors, and partnerships with trusted cultural groups to ensure inclusivity and accessibility. The rationale for the mental health equality advocacy program is grounded in the urgent need to reduce persistent mental health disparities that prevent minority communities in Houston, Texas from achieving equitable health outcomes. Research consistently demonstrates that minority groups encounter more barriers to care but receive fewer services and report lower satisfaction with treatment. Without intervention, these inequities continue to grow, resulting in avoidable suffering, economic burden, and diminished quality of life. First, addressing disparities is a matter of social justice. Equitable access to mental health care is a fundamental human right, yet systematic inequalities continue to deny minority residents the care they deserve. The program is designed to confront inequities by providing culturally informed, accessible, community-based services. Second, improving mental health outcomes benefits not only individuals but the entire community. Untreated mental health conditions contribute to homelessness, unemployment, substance use, incarceration, family instability, and chronic medical conditions, issues that impose long-term financial strain on social systems. By reducing untreated mental illness, we reduce community burden and promote overall well-being. Third, minority populations in Houston, Texas have expressed a strong desire for culturally competent services. Many individuals report having no connection with traditional healthcare providers due to language barriers, cultural stigma, or previous negative experiences. The Mental Health Equality Advocacy Program is designed to directly address these concerns by integrating multilingual services, community partnerships, and culturally validated outreach strategies. The logic models includes inputs resources, such as human resources, licensed mental health professionals, community health workers, social workers, peer support specialists, and certified interpreters. 2. Training resources, culturally responsive counseling curricula, implicit bias reduction training modules, and continuing education materials. 3. Community resources, partnerships with minority-led organizations, faith-based groups, local clinics, and cultural centers in Houston, Texas. 4. Technology, telehealth platforms, secure electronic health record (EHR) systems, multilingual patient portals, and mobile devices for virtual outreach. 5. Supportive services, transportation vouchers, childcare support during sessions, and referral networks. 6. Findings, grants from public health agencies, local foundations, community mental health block grants, and private donors. 7. Raw materials, minority populations in Houston, Texas are experiencing limited access to mental health services, cultural and linguistic barriers, stigma, and socioeconomic constraints that prevent early intervention and treatment. Activities, including community outreach, conduct culturally tailored community mental health workshops, stigma reduction seminars, and wellness fairs within minority neighborhoods. 2. Service delivery, provide individual, family, and group counseling using culturally competent, evidence-based modalities through in-person and telehealth options. 3. Provider training, train healthcare providers in cultural humility, trauma-informed care, and implicit bias reduction to enhance the quality of service. 4. Educational resources, develop and distribute multilingual brochures, digital toolkits, culturally adapted psychoeducation videos, and mobile app-based resources. And 5. Navigation support, offer case management, follow-up calls, appointment reminders, and assistance with insurance enrollment. program establishes a structured set of goals and objectives designed to guide efforts to reduce mental health disparities among racial and ethnic minority adults in underserved Houston communities. The overarching goal reflects the program's intention to expand access to culturally competent, community anchored, and linguistically responsive mental health services. By addressing barriers such as stigma, mistrust, limited provider diversity, and inadequate service accessibility, the program aims to strengthen early engagement, improve service utilization, and support continuity of care throughout a 12-month implementation period. The goals are operationalized through a hierarchy of outcome and process objectives that specify expected changes and the activities required to achieve them. The outcome objectives focus on three major areas, such as reducing untreated mental health symptoms, increasing service utilization, and decreasing stigma within minority communities. Each final objective is time-bound, measurable, and directly tied to indicators such as screening data, service utilization records, and standardized stigma assessments. To support these long-term outcomes, the program includes intermediate objectives that outline the necessary milestones. These objectives include conducting large-scale culturally tailored screenings, strengthening referral systems, implementing community outreach events, and enrolling clients in mobile or neighborhood-based counseling services. It also involves delivering culturally grounded psychoeducation workshops. The intermediate objectives serve as essential building blocks by ensuring that minority adults are reached, engaged, and connected to appropriate care. The process objectives and corresponding activities operationalize the work required to meet intermediate targets. These include deploying bilingual outreach teams, conducting weekly mobile screening events, creating multilingual educational materials, equipping mobile counseling units, developing a stigma reduction workshop curricula, training facilitators, and establishing referral agreements with community-based agencies. Collectively, these tasks ensure that services are accessible, culturally aligned, and responsive to community needs. Together, the goal and objectives framework provides a clear roadmap for program planning, implementation, and evaluation. By linking culturally competent service delivery to measurable community level outcomes, the program ensures accountability, supports continuous improvement, and advances its central aim, promoting equitable mental health access and reducing long-standing disparities affecting minority populations in Houston, Texas. The program design establishes the data structure necessary to evaluate whether the culturally responsive, community-based mental health intervention effectively reduces disparities among racial and ethnic minority adults in Houston, Texas. Building on the previously developed goals and objectives, this section identifies the inputs, throughputs, outputs, and outcomes required for systematic monitoring and performance measurement consistent with evidence-based program design principles. Inputs represent the resources foundational to program operation. client level, data include demographic characteristics, primary language, insurance status, socioeconomic indicators, screening results, and referral source. Staff inputs capture demographics, credentials, languages spoken, cultural competence, and trauma-informed care training hours, caseloads, and schedules. Material resources consist of multilingual screening tools, educational materials, psychoeducation packets, and referral directory components. Facilities and equipment include mobile counseling unit locations, private counseling spaces, and technology used for documentation and referral tracking. Collectively, these data allow the program to monitor workforce readiness, resource distribution, and equity. Throughput refers to the services delivered and methods used to implement them. The program includes five major service categories. 1. Culturally adapted mental health screens. 2. Structured referral and care navigation using motivational interviewing. 3. Community outreach events designed to enhance awareness and reduce stigma. 4. Mobile counseling sessions offering free or low-cost therapy in targeted neighborhoods. 5. Psychoeducation workshops addressing cultural beliefs and stigma. Each service type has clearly defined tasks and relies on culturally responsive intervention strategies. Intermediate outputs track the volume of service delivery, such as the number of screenings conducted, referrals issued, outreach events held, mobile counseling sessions provided, workshops facilitated, and total participants reached. Final outputs document completion of key service milestones. For example, successful referral, follow-through, or completion of a counseling cycle. The design also specifies intermediate outcomes, including improved identification of mental health needs, increased engagement in counseling, enhanced knowledge of mental health concepts, and expanded community awareness. Final outcomes measure overall program impact, such as a reduction in untreated mental health symptoms, increased service utilization, decreased stigma, strengthened continuity of care, and heightened trust in community-based services. These components collectively create a coherent data system that supports ongoing accountability and evaluation. A fellow chart provides a visual representation of how clients move through the program, helping stakeholders clearly understand each step in the service process. It simplifies complex operations by illustrating the sequence of actions from initial contact through program completion, ensuring transparency, accountability, and effective communication across staff and partner organizations. The process began with entry and initial contact, where clients access the program through community outreach events, referrals from partner agencies, or walk-up interactions at mobile units. At this stage, staff collect basic demographic information and review informed consent procedures to ensure clients understand their rights and the voluntary nature of participation. Next, clients complete mental health screening using culturally and linguistically appropriate tools. Screening results are recorded and staff determine whether additional services are needed. This data drive the triage and referral decision where staff evaluate whether the client should receive brief on-site support, be referred to a culturally competent provider, or enroll directly in mobile counseling sessions. Clients requiring external support are guided through a referral process during which staff document their referral details, provider information, and follow-up expectations. Those who continue within the program move to service enrollment, which may include mobile counseling or participation in psychoeducation workshops. Enrollment is captured through electronic systems and activity logs. Once enrolled, clients enter the service delivery phase, receiving counseling, psychoeducation, or both. Staff document attendance, progress notes, and satisfaction indicators to track engagement and service quality. This is followed by monitoring and follow-up, where staff conduct check-in to ensure referrals were completed, assess ongoing needs, and support continued participation. As clients near the end of their involvement, they reach program completion where they finish their service cycle and complete a satisfaction survey. Final outcome measures such as symptom reduction, stigma changes, and service utilization are collected at this stage. The process concludes with termination and aftercare, during which clients receive additional resources, referrals, and optional follow-up guidance to support long-term well-being. Management. Formative evaluation. Formative evaluation, also referred to as process evaluation, is used to monitor whether program services are implemented as intended and whether daily operations align with the program design. It examines how effectively resources are used, how well a staff perform assigned duties, and the extent to which participants engage with screening, referrals, mobile counseling sessions, outreach events, and psychoeducation workshops. For this program, formative evaluation will help determine whether staffing levels are adequate, whether services are culturally responsive, whether client flow is efficient, and whether activities reach minority populations as planned. Using Suchman's levels, evaluation of effort, and evaluation of cost efficiency, the program can assess operational quality, productivity, and resource stewardship. Summative evaluation. Summative evaluation, also known as outcome evaluation, measures the extent to which the program achieves its intended results. For this intervention, summative evaluation determines whether culturally competent services effectively reduce barriers to care, increase mental health service utilization, decrease symptom severity, and lower stigma among minority adults in Houston, Texas. Guided by Suchman's levels, evaluation of outcome, and evaluation of cost effectiveness, this component assesses both the measurable impact of services and whether the magnitude of those outcomes justifies the financial investments required to deliver them. The General Health Questionnaire 12 (GHQ 12) was selected as the primary performance measurement tool because it effectively assesses overall psychological distress in community-based populations. Unlike disorder-specific instruments, the GHQ-12 captures a wide range of mental health concerns, making it especially suitable for programs serving diverse minority adults with varying levels of unmet mental health needs. Its brevity, strong strong psychometric validity, and cultural adaptability enable staff to administrate it efficiently during outreach events, mobile counseling sessions, and follow-up assessments. Using the GHQ-12 strengthens both formative and summative evaluation processes. Formatively, it helps identify early signs of distress, inform triage decisions, and determine whether clients need brief support, counseling, or external referrals. Summatively, it provides measurable outcomes that reflect changes in symptom severity, emotional well-being, and overall engagement with mental health services over time. The tool also supports program goals related to reducing disparities by offering a standardized way to track improvements across different cultural and linguistic groups. Because the GHQ-12 is widely recognized, easy to administer, and sensitive to changes in mental health status, it offers a reliable method for evaluating program effectiveness, guiding resource allocation, and documenting progress toward improving community mental health outcomes. Impact evaluation examines the long-term and community-wide effects of the program. Unlike outcome evaluation, which focuses on individual level changes, impact evaluation assesses whether the program contributes to lasting reductions in mental health disparities across minority communities in Houston, Texas. This evaluation asks larger questions such as: has the program increased equitable access to mental health care? 2. Has cultural stigma decreased at the community level? 3. Are minority residents more comfortable seeking help? 4. Are mental health outcomes improving over time? Data sources include community health surveys, collaboration with local clinics, demographic service utilization data, and longitudinal tracking of participants who remain engaged in the program. Impact indicators include reductions in mental health service gaps, increased cultural competence among regional providers, decreases in untreated mental illness, and improved overall psychological well-being within minority populations. The budget for the Mental Health Equality Advocacy Program is structured as a line item budget to provide clarity and transparency. The major cost categorizes include personnel, program supplies, outreach materials, technology, facility expenses, and administrative overhead. Personnel is the largest budget category and includes salaries for licensed mental health counselors, bilingual community health workers, case managers, program coordinators, and administrative staff. Personnel costs also include professional development, cultural competence training, and employee benefits. Program supplies include screening materials, mental health assessment tools, office supplies, educational handouts, and culturally tailored brochures. Outreach costs include marketing materials, social media campaigns, and community event expenses. Technology expenses cover telehealth platforms, laptops, secure data storage, and software for tracking evaluations and performance metrics. Facility expenses include renting community spaces for workshops, support groups, and counseling sessions. In-kind partnerships will help reduce facility costs by utilizing churches, schools, and community centers. Administrative overhead covers insurance, financial management, record keeping, and compliance with grant requirements. This line item budget ensures that each component of the program is fully supported, sustainable, and aligned with expected outputs and outcomes. Funding for the program will be secured through a combination of grants, community partnerships, and local contributions. The primary funding sources include federal and state grants such as Substance Abuse and Mental Health Services Administration (SAMHSA), Community Mental Health Block Grants, Health Resources and Services Administration (HRSA), Behavioral Health Integration Funding, and state-level mental health equity initiatives. Local foundations, including the Houston Endowment, the Brown Foundation, and culturally focused philanthropic organizations, offer grant opportunities for programs addressing health disparities. The program will also seek support from corporate partners in the Houston area, particularly companies with diversity, equity, and inclusion goals. Partnerships with hospitals and clinics will provide in-kind support, including free space, shared staff, or technology resources. The program will also explore collaboration with universities for research support or graduate student interns. Finally, community fundraising, events, and donations from faith-based organizations will help sustain community engagement and long-term support. And in the conclusion, the program is a comprehensive, culturally responsive initiative designed to reduce mental health disparities among minority populations in Houston, Texas. Throughout this presentation, we examine the nature of the problem, the target population, the relational behind the program, its goals and objectives, and the evidence-based components that support accessible community-centered mental health services. The program integrates outreach, early intervention, counseling, support groups, case management, and cultural competency training to ensure that services are not only available but truly effective in addressing the unique needs of diverse communities. Through ongoing formative and summative evaluations, the program remains grounded in accountability and continuous improvement. Ultimately, the program seeks to empower minority communities by increasing awareness, reducing stigma, improving mental health literacy, and expanding access to equitable care. With sustainable funding and strong community partnerships, the program has the potential to transform the mental health landscape in Houston, Texas. And these are all my references that I use for my presentations. Well, thank you everyone for listening to my presentation. I appreciate your time and I'm happy to answer any questions. So please feel free to share your feedback and I will be so happy to read them all and respond to each one of them. Thank you and hope everyone have a wonderful evening and holiday.